Good afternoon, and welcome to B-Sides Las Vegas's I'm the Cavalry track. We'd like to thank our sponsors, especially our diamond sponsors, Adobe and Aikido, and our gold sponsors, Profit and Run Zero. It is their support, along with our other sponsors, donors, and volunteers, that make this event possible. These talks are being streamed live, and as a courtesy to our speakers and audience, we ask that you check to make sure your cell phones are set to silent. If you have a question, there will be an audience microphone set up towards the back of the room. And so if you have questions, please use that microphone so that the YouTube live stream and everyone in the room can hear you.
Very good. This panel is so important. There's actually 3 introductions. So that helps you understand how important this is. So I wanted to touch briefly on photography. Each of the members of the panel have agreed to have you take their picture as makes sense for you. So you can take their picture, but you can't take other people's picture if you do not have their permission. So right now it is my honor to introduce the co-chair of this track, Mr. Josh Corman, who has some profound words of welcome for our panel. Mr. Corman.
It seems so formal. Who was here for the opening yesterday? Okay. So some of you saw a video. We're going to play a video because neither Dr. Christian Dameff or Nurse Dina have seen it. We don't have to play it yet. But if you've been tracking the Cavalry since we started 12 years ago, we care about everywhere bits and bytes meet flesh and blood, but we have a particular soft spot for healthcare. And it was really meeting someone in med school, working with the FDA, Beau's origin story. The overwhelming lion's share of the trust that we built with the federal government was with healthcare, medical devices, healthcare technology, delayed degraded care. So this is always my favorite topic block of them. And we have some people you know, like Beau, some people you might have seen in previous years, like Christian. And we went from the idea of could cyber disrupt patient care, loss of human life? And now we've got legions of peer-reviewed studies talking about the impact of delayed degraded care. So we're really happy to have, not only did Christian help found Cyber Med Summit as a 501c3 to pull together clinical technicians and nurses and doctors and medical stakeholders to meet them on their turf, learn their love language, find out common cause and common purpose. But that has kind of become the blueprint for what we're now doing with Undisruptible for water engineers and power. And, you know, we had to build those muscles and trust. So this is my favorite topic each year. I'm really happy to do so. And then last year, we have a brand new teammate from the medical world, Dina. And I can't wait to have each of you meet her. And she's a sponge learning this stuff. But, like, what does it look like to a non-cyber, non-IT person when we fail or when we have disruptions? So please have a warm welcome to these folks. We'll play a video, and I'll get the hell out of the way. So, everyone. All right, 2-minute video.
Picture a hospital. Picture your hospital. When was the last time you were there? Was it to welcome a baby into the world or to say goodbye to a loved one? No one wants to need a hospital. But when we do, we depend on timely access to care, when and where we need it. Irrespective of cause, delayed and degraded care for time-sensitive conditions can affect worsened outcomes and even loss of life. A 5-minute longer ambulance ride has a significant impact on 30-day mortality rates. Time is brain, where even an hour or few could determine if you walk again, if you talk again, if you even survive. Now picture your hospital. What if that hospital was not available to you? If your hospital was disrupted, where would you go instead? Is it across town? More than an hour away? What if they are also down? The chance is not as remote as you'd hope. Hospitals have become a top target of ransomware, cyber attacks that cripple technologies in the vital path of care delivery. Worse, your hospital doesn't even need to be the one attacked to endanger you or your family. We've seen a 10-fold decrease in favorable outcomes for heart patients merely due to excess strains of a ransomware-affected region. Now back to your hospital, back to your family. You and your family deserve better. If we want timely access to patient care and more resilience in the face of accidents and adversaries, we're going to need to advocate for ourselves now. As we head into an era of hybrid conflict with threats to water and power, these disruptions stand to get a lot worse. But we'll talk about that in another video.
As Josh mentioned, this has been a topic, a staple, if you will, of the conversation. And I bet many of you folks have been, raise your hand if you've been to this event previously. All right. Keep your hand up if you're bored of healthcare cyber. This person in the back. All right. I'm going to take another little audience poll here. Raise your hand if you feel like we've made significant progress since the last time you were here in healthcare cyber. Raise your hand if you feel like we've really made big advancements in ransomware in hospitals or medical device cybersecurity. Raise your hand. Man, that kind of sucks. I don't think this, what we're going to talk about is intended to be a bummer. It often is because we're talking about some pretty serious things. And I loved that video and it talked about how no one wants to meet a hospital, but we all, most of us, are going to. And when we do, we're going to hope that it is operating at its highest efficiency. And then every doctor and nurse and technician in that place ate their Wheaties for breakfast that day because it's going to be us or our loved ones. And what a dystopian nightmare we all live in now that we have to have these conversations about whether or not the basic technology that enables all this care might not be available for you because of something like a ransomware attack. So what we hope to do here in the next couple hours is give three varying perspectives, kind of slices of this, and bring some alternate perspectives into the conversation to try to convince folks that haven't been familiar with this previously that this is a deal, this is an issue that you should care about. Two, empower you to do something about it. And then three, start thinking about this from a little bit of a broader lens. Much of the amazing content that we've had in this track the last day and a half has been discussions about national security, international security, things with increasingly sophisticated adversaries. And discussing this as more of a strategic or a larger goal, a larger kind of picture is, I think, something that's really prudent for us to talk about there at the end. So each of us are going to take a little bit of time to give our individual perspectives, and then we're going to be able to open it up to some questions at the end and hopefully engage you all in a dialogue, because I think one of the best things about B-Sides is that you guys aren't passive receptors of this information. You're really supposed to be active participants and collaborators. And if we had it figured out and we were just here to present it to you, I mean, we'd have mansions and we would be like on jets and stuff. No one's got it figured out. And you might be the person that has that revolutionary idea, and you being here in this talk and listening to this and then collaborating and working on this problem might be the thing that cracks it or moves it or saves a patient's life eventually. So we hope to empower you with that kind of voice at the end. You know, we talk about some pretty heavy stuff. I don't think we need like official trigger warnings or anything like that. But I do think that this can be, sensitive information. We're talking about scary scenarios and patients. And if you are sensitive to that, just consider that. I don't personally have any materials. At the end, I'll have a little bit of a PowerPoint presentation. I don't have any videos or images that might be disturbing this year. Sorry about last year. So I think that's it for our trigger warnings and kind of the introduction. Anything else you guys want to add before you kick it off, Beau?
No.
Yeah, all right. Let's do it.
All right. So my name is Beau Woods. I started my career working in a hospital. Anybody here work in a hospital now? Worked in a hospital? Worked in a hospital on the IT InfoSec side? A few people. Cool. So there are going to be some people in here who laugh when the rest of you don't, or who cry when the rest of you don't. But I think I was at the hospital for almost 3 years to the week. And I saw a lot of stuff happening on that network. Over at some of the other big conferences, they like to say it's the world's most hostile network. Well, they are right. It is extremely hostile over there. But not too far behind that is hospital biomedical networks. Because you have all flavor of types of devices, all types of generations, and you have a lot of malicious software that just bounces around the network there. You know, network worms that you haven't seen on in places for a decade or more. They still exist. They still live in these isolated environments, like a niche isolated environment where you find like crypto animals, like things that time forgot, right? You can still find probably like SQL Slammer worms, which was back in 2003, I think. You can still find some of those old things running around some of these networks, just because of the nature of healthcare and hospitals. Like I said, you've got all of these systems of different generations that are there. And a lot of times, you know, in a hospital, I would be working on troubleshooting things that weren't even malicious, probably. And so when in the Cavalry we talk about accidents and adversaries, malicious intent is not a prerequisite for harm. I remember one case where we had all of the medical devices of one class, I think it was an infusion pump, would flash every 15 minutes like clockwork. And so it was really, really scary because these are in every hospital room pretty much. And we traced it down to, there was this network packet that one of our IT systems would send out, polling every device in the hospital to see if it was up, to get a telemetry readout, to get just other basic IT information. It was like a proprietary version of SNMP, if you're familiar with that protocol. And these medical devices didn't like that, so they would bounce. So we disabled that packet being sent every 15 minutes. But you deal with a lot of things like that. Who here thinks strong passwords, multi-factor authentication is generally a really good practice to have, other things being equal? All right, pretty much everybody. Who thinks that if you can't do that, you should probably at least just have strong, unique passwords? Everybody has their own credential to log into a system. Yeah, pretty much everybody. Who here thinks at a minimum you should have shared passwords that everyone knows? One person. Who here thinks that that's probably a bad idea? Well, I'll tell you how I found out that that was a bad idea, and it might be different than what you expected. So for certain types of systems, we had a setup where the computers themselves had no passwords on them. So anybody could walk up and they had instant access to the desktop. I saw that as a pretty big problem. And so I went to my boss at the time and I was like, boss, we got this security thing over here. We should probably do a thing. And she said, okay, well, talk me through it. And so we talked through it for a little bit. Said, all right, I tell you what, come back with me on Saturday night. We'll go into the ED and we'll just sit and look at how these computers get used, so we know that there's nothing in the way. You know, when you put passwords in front of things, you could put something in the way. So sure enough, I went, looked, and after about an hour or two of sitting there and watching, seeing, you know, every 15 minutes, you'd probably have 6 to 7 people come and touch every single PC. And if they had to individually log out, log back in every time to that, how much time would be lost? And this is the emergency department. You've got people coming in with critical cases where, you know, seconds can save lives. And certainly the cumulative effect of minutes of extra login time between these things, with the system having to log out, come back up, oh, somebody forgot their password, they got to call the help desk, 15 minutes for a password reset.
It's true.
That's a pretty big deal. So after that, I no longer ask whether we should put passwords on things anymore like that and have, you know, strong multi-factor. Multi-factor didn't really exist 20 years ago, but like those are the types of things that you deal with in hospitals and in healthcare environments that are unique and different from other environments that you might deal with. I also remember going in and we had a push, an initiative that all the systems across the hospital should have antivirus on it. Good idea, right? It's a at least a minimal protection against known bad software that will stop something when it pops up there. But we had all these medical device vendors who would come in, and they're all special and they know how to make medical devices really, really well. And sure, they're on the top of their game in security, but security isn't really important because it's safety that you care about. So it's all right, well, how does it react if you put antivirus software on there? They're like, well, it's not really approved. We don't want to go through FDA clearance again for that. By the way, that's a red herring. The FDA never says you have to go through clearance if you put antivirus on it or send patches. But a lot of medical device makers don't know that. They're getting a lot better though. So anyways, we went and we worked with the vendor. We did a site demo. They came out, they said, all right, here's the workstation that will control this device that sits bedside with a patient. And this is going to be the remote piece of that. You can put antivirus on this remote piece of it, and let's see what happens. So we installed, Symantec or whatever our antivirus du jour was. And instantly their clinical app crashed. No warning screen, nothing. It just fell to the ground. Like, all right, what's happening? Let's try it again. Let's reboot the computer, bring it back up, start it up, see what happens. Sure enough, the same thing happened. So went back and looked through the logs. When we had enabled antivirus, we didn't realize it, but their software was using obfuscation techniques that malware uses to hide itself from the operating system in order to, protect their intellectual property from people being able to see it or whatever. I don't know why they were doing this, but the antivirus would detect that and kill the software, just stop it from running and, quarantine it, put it in this safe space. And so we learned that, you just can't put antivirus on those types of systems unless you can control it and make sure it's not going to accidentally kill the clinical software that's running to help patients. So again, an eye-opening moment. And then when I said, hey, we've got the opportunity here to do some other things where we could put, maybe allow listing software that only known good apps can run on the system. My boss said, all right, cool, create this business justification for this. Like, all right, cool. I went away, put together a one-page document. After a few iterations, it was non-technical enough that we could take it to the business leadership team. And the price tag on it was like $250,000. I'm like, I went and I negotiated with the vendor. We got it down to the cheapest thing it could possibly be. This is the least expensive product on the market. I said, all right, well, what I don't see in here is what's the trade-off? For $250,000, we could get 2 to 4 more nurses. We could get another physician in here. Which is going to deliver better healthcare? It's like, oh, shit. So I had to, crumple up that piece of paper and throw it away because I knew the answer to that. So those are the types of challenges that people in healthcare IT face every single day. For me, the most profound one that I experienced, and this is where Josh and I bonded day one of I Am the Cavalry, right after he had launched. He and I were both in the speaker's room upstairs here, talking about different things. And I told a story about literally my first day working security in a hospital was we had a network worm that was going around. It was Zotob. If anybody remembers back, I think it was 2007, 2008, something like that. It was this malicious software written by I think it was a Libyan and a Turkish guy, and they were trying to steal banking credentials, right? So like this is supposed to go out and like hit grandma's PC, steal her banking password, and then they're going to go drain the accounts. They were using IRC as command and control, so like it wasn't super sophisticated even for back in the time. But it was going around our hospital and knocking systems offline left and right. We managed to get it under control on a lot of the systems that we had. We sent out patches. I think we patched a couple of hundred servers within a day to update it to avoid this type of thing. And we're like, all right, we're good. We're back up and running. The next day I came in and I had a couple of messages. So I called up the department. It was the natal intensive care unit. I said, hey, you left me a message, calling you back. What's going on? They said, well, we know you're not working on medical devices. We've got the whole biomed department that does that, but they can't really help us with this problem with one of our devices. So we thought we'd call you. What happens is about once an hour, this system randomly shuts down. And then when it comes back up, there's a Windows screen on it. We didn't know it was running Windows. It's just one of our medical devices. It's the fetal heart monitor, the thing that is making sure for those babies that we know what's going on with them. And if you don't know, those devices are a massive force multiplier in hospitals. They allow many more patients to be taken care of by many fewer nurses, physicians, and others. So when those are down, there is a huge resource drain on the people in that department. There is also a consistency of care issue, because if you've got to then attend to more patients than you're used to, you've got to move a lot faster. When you move faster, when you're higher stress, you'll make more mistakes. And computing technology, they just do that reliably, repeatably, right? It's why we use computers. It's why we use these devices, is because we have clinical studies that say they're safe and effective for use, that they can outperform just nursing staff and physician staff alone when they work together with them. So they're like, this is a big problem for us. I said, all right, well, let me see what I can do. So I went up there, checked it out. Sure enough, they were computers running the same operating system. I don't remember. It was like Windows 2000 or something, that had this same vulnerability. It was a medical device. So first thing I did is I called up a medical device manufacturer, said, hey, you guys have this problem. Can you do something about it? And they said, well, it's a medical device, so we can't add patches to stop the malicious software from running on it. Like that, what are you, crazy? You want to fix a computer? You want to fix a medical device that's being attacked by adversaries? No. We would have to go through a whole FDA cycle. And again, not true, but that was the line that they were sticking to. I said, all right, well, is it okay for me to add the patches? I said, no, you'd be out of your warranty. Are you crazy? Why would you want to, put well-tested, reliable software on something in order to keep out the known malicious software? Like, that's crazy talk. Don't do that. So I said, well, all right, that's not really how I'm wired. I'm wired like a hacker. I see a problem. I'm going to go fix the problem. And if there's something in the way, we'll look at the trade-offs. We'll worry about those. We'll make a business decision or some kind of a good risk decision based on that. And then we'll take action. So that's exactly what I did. Is again, I wrote this business justification, having learned a lot of lessons from the first time I tried this, brought it to my boss. We took it up to the CEO of the hospital, asked a couple of questions like, wait, so you're telling me that we have a problem right now that may have an impact to patient safety? Yep, that's right. And what you're proposing might void our warranty, but our warranty is already void anyways because the devices don't work. It's like, yep, that's right. He's like, well, this is a no-brainer. Signed off on it. We had all our permission. And so I used the Metasploit framework to hack these medical devices, to then install the patch, kill the malicious software, and reboot the box, get it back up and running. Checked in with the NICU, the Natal Intensive Care Unit. They said, yep, those systems are all up. If we have any other issues, we'll let you know about it. But one of the reasons that Josh and I connected is I said, I've been in InfoSec for 10 plus years at that point. And that was probably the day that I had the most profound impact on people's lives, is being able to help get those systems back online so that the people who take care of other people, some of the most vulnerable patients in the entire hospital, could keep doing their jobs. And so that for me was a very formative moment in my InfoSec career, and also something that has made me extremely passionate about medical device security, about hospital security, about security of these other lifeline systems that we depend on, like water, like power, like aviation, like other things. So that's my set of storytelling, and I'll hand the baton over to Dina, who will pick up from there.
I just want to say thank you. Here, should I come this way?
Sure.
Because I have to get my Braille computer, my little notes. So anyway, let me, I just want to thank you so much for caring. That I feel like our IT people try, but like to be a force and continue the battle all the way up to the CEO, because they don't care. And I feel like I think I'm the thorn amongst the roses right now, because I feel like I'm a science major, but I'm like knocked out by how smart everyone is and how much I'm learning. So let me log on here real quick. And sorry about this.
She does have a password on her computer, by the way, much more secure than some places.
No, I don't share my password. At least I'm that far, though. Christian lectured me very kindly and said, Dina, get a VPN. So I will do that. So I'm Dina Carlisle. I'm a critical care registered nurse. I'm the president of a union. My story is we represent two different hospitals. And the first one is how I met Josh. We were introduced by a reporter who was investigating 140 hospitals going down, and one of them was who I represented. I represent two groups over at Ascension, which is now Henry Ford, Rochester. I have a large group of registered nurses and a group of radiology technologists. At McLaren Macomb, which is about 13 hospitals in their system, they may have lost one, that I have a group of, the biggest group of nurses and a group of service group folks. The service group people are your phlebotomists, the sitters who sit with you when you're not safe to be alone, the people who register when you come in the hospital. So that's the kind of people we represent. It's all healthcare. My local stands for safe staffing, pure and simple. That's like our hill to die on every day. In 2004, McLaren Macomb went on strike, indefinite strike. We were out for 6 weeks. It was very painful, but we took a less percent of money and we got a safe staffing matrix at that house. And I'm very, very proud of that. However, from 2004 to now, there's a lot lost in translation. 3 years ago, I put some pretty big teeth in the last contract. I put a big penalty if they violated the safe staffing matrix. They violate it daily. Never in my wildest dreams did I think they would pay later instead of staffing up front. So I guess I'm trying to paint a picture of where healthcare really is. Our sister hospital at Ascension/Henry Ford has no safe staffing matrix, and we are fighting very desperately for that. In June and July this year, both houses went out within 30 days on strike. Again, fighting for safe staffing. One needs a matrix, the other I'm trying to tighten down. Christian and I were discussing like how EDs are so severely understaffed, so severely. And it's never about money. It's about safe staffing and protecting our patients. We survived COVID. One hospital, McLaren, where I work, was hit very, very badly with COVID patients. We had a refrigerator truck out back that was a morgue. So I want to tell you, I've never seen that much death in my life, and I pray I never do again. So imagine healthcare workers' surprise when a cyber attack took us to our knees again. You just don't see this coming. I mean, I'm just now learning the things at such a basic level from all my new friends, and like, what a warm group of smart people you are. So thank you for helping me on this journey of learning what I need to do, because it's taught me a lot. The bigger hospital lost 200 RNs post-COVID. Our Ascension Hospital lost about 100. And the service group lost about 100 folks also. Make no mistake, there is not a nursing shortage. There is a shortage of nurses who want to work in these environments. It's not safe. So I thank God for the people who are fighting to make this safer for everyone. And you don't see it coming. We didn't see this coming, that a cyber attack would cripple us the way it did. So you've all heard of an electronic medical record system, right? We have become very reliant upon it. I've been an RN since 1996. So back in those days, we were chiseling away on paper our charting. I'm aware of what to do. I know my dosages in a different way than these smart young people who are coming up. But let me say, when this occurred, the first one was, I want to say, let me see, get my dates again, May 8th for Ascension and August 5th for McLaren, within months of each other. So we have new baby doctors and nurses who are coming in and have never written on paper before. We have hospital systems who have paper charting that's stuffed in like little areas where we don't even know where it is. The Ascension Hospital, now Henry Ford, had a little bit better of a system that did not go down very frequently. McLaren, it stinks, it goes down like for a few hours, once a month. Every time I think they reboot the system or upgrade the system, right? It, like the next morning, it's like chaos, we can't log in, so patient care is delayed. Those EMRs not being available to us as clinicians, these people came in, you would be shocked at the amount of people who don't know what medication they take. You would be stunned. And you men are the worst. So y'all better learn what you're taking, because your women, it's always like, when I do a pre-op day, well, my wife knows all my medicine. That's, you know, that could be a deadly mistake someday. So be on your best behavior. So we go forward. I've got young doctors who are used to clicking, and I say this with great love, Christian, who are used to, like, we're all used to clicking boxes in the computer for our orders, to get things done, to get patients different places. There's no box clicking. These people had never written out prescriptions. You know, we do, like, the prescriptions go straight to the pharmacies now. This is a huge problem. So now they're writing prescriptions. I was discussing this with my executive board. What was the worst thing that happened to you when we were down? She said, I had a doctor write Tylenol and like walk away. Like no dosage, no route, no nothing. You know, these things are important and can be life-threatening. So, you know, we were really helping our young people, and our young nurses who had never charted on paper were just as new. You know, they didn't know. So then the hospital has no preparedness, no communication. During COVID, we had a different chief nursing officer and a different vice president of HR. Every 3 hours, they pulled me out of my job. I was helping them make decisions on what we were going to do as staff in the hospital. This was a far different animal, different CNO, different VP of HR. They didn't care. They didn't want to include us. The nurses are, I'm telling you, there's 50,000 nurses in Michigan who are not working, who have a license, because they can't take the stress of doing this anymore. They can't do it. We can't not take the best care that's possible of our patients. So to go forward from that, The EMR, it provides us with allergies, what medicine you're on, what surgeries you've had, your medical history, lab work, diagnostic testing. That system that was a great safety net for us since it's come on board, like really decimated us when we lost it. So we didn't know what your lab work was. And let's talk about our phlebotomists who are trying to care for you and draw your blood. It was so time consuming. We had patients going into surgery with no lab results. People who are on different medications, we need to know their lab values. If you're going in for a surgery and we think that you might be losing a lot of blood, that's invaluable. We need to know that before you go into surgery. But I'll tell you what, we worked for a corporation, they didn't care. And as all my friends here have said continually, I loved Joshua's mantra, no one's coming to save us. We all better rise up. And that's what my union is doing. So let's see. At one hospital, a pre-op nurse had to call every single floor to find the patient. We didn't even know where patients were. It was really dark. And I believe that due to the lack of a computer system in place during this time, there were errors. I think there were people who had very legitimate bad outcomes. And I think it's going to be easy to just brush it under the rug because there's no clear record of it. And that is so disturbing. Medication administration. This is very frightening. There's a machine that is in our medroom, and it's either called a Pyxis or Omnicell. Everybody may have a different type of machine that they go into. My fingerprint gets me in. We were overriding every medication and just taking it out. There was no second checks with pharmacy. There was no second checks from the pharmacy system that went into the Omnicell or Pyxis, whatever anyone's using, to stop, a hard stop for any medication that could be wrong. We had to be the ones to catch any errors. We found discrepancy from doctor's orders. We were used to pharmacy like being that second hard stop. Hospitals began asking the patients to bring in their actual prescription bottles, to bring in their own lab work printed scripts for testing, and as Beau referenced, the connection between our computers and all our devices. We've talked about before how certain IV pumps can like deliver a lethal dose of medication if we're not careful. So, I mean, kudos to our IT friends who are there for us. The McLaren site is a level 2 trauma center. We continued through all that, taking in patients from all over. They're kind of like a little hub, and everyone would deliver all their patients to us. So we're already overburdened. The understaffing was horrific, and we're still taking in critical patients from other facilities. This just can't happen. And what is that? That's profits over patients, without question. And as we've all said, with those delays in care, due to us searching for medication, verifying, trying to find lab work, what was the outcome? I think Christian was going to reference this later. What are the or possibly do a study on it, I think you said, but like what are the outcomes for these folks who were sent elsewhere? And so I was jamming on Christian on some YouTube, and he did a study that really caught my eye, that it showed the spike in surrounding hospitals. So if my hospital was down and we sent it to another hospital, that hospital can be overwhelmed. As I love that little video, Josh, well done. That time is brain. Even with cardiac things, minutes make a difference in your outcome. Whether you're going to speak again, be able to swallow, all of these things. And when you're diverting people and we're not ready, and we're still not ready, my key thing that is my biggest thing and closest to my heart is safe staffing. So every type of nursing has a different person or association, critical care associations for the ICU. It's like 1-to-1, 1-to-2. Hospitals violate these things daily, and you don't know it when you're a patient. And every one of you, at some point in time, you're going to be a patient or you're going to be a family member there with a patient. And to see these things is heartbreaking. So this is staffing ratios save lives. They do so many good things. And as I said, hospitals violate these ratios daily, and they don't even flinch. They're not even afraid to pay the penalties. They don't blink an eye over that. Some nurses in the med-surg areas can have up to 8 to 12 patients. It's not possible to care for that many people. Not on your best day, not on your best game. So I think people need to realize what's actually going on within hospitals. I want to add that staffing ratios reduce mortality rates, shorten hospital stays, improve patient satisfaction. Patients have fewer adverse situations, falls, things like that. Simple things that we need to take care of. Faster detection of patient deterioration, reduced medication errors. Financial benefits, it's cost effective. It decreases readmissions. How did my little local fight? We had a generous cyber journalist presence that brought our story forward. Our demands were as follows. Because we had little interaction with our administration at both hospitals, we asked for unit shift huddles to be able to have some communication over safety issues, what they were doing, what we could improve upon, and none of that was occurring. Secondly, we asked the hospitals to conduct regular training sessions. I have begged for this for the past year plus. It's not happening. So this new wave of baby nurses and baby doctors still aren't learning those things that are imperative for our patient safety. Third, weekly progress reports to update staff on the status of efforts to resolve the cyber hack incident and restore access to the EMR, address any safety concerns, staffing issues. Number 4, patient ratios. We chose 1-to-4 for the bigger units, and we kept the critical care units at what they were, 1-to-1 for ICU, 1-to-2, that kind of thing. Step down is 1-to-3. We tried to fight for a reduction of elective surgeries and transfers in. It didn't happen. They kept doing elective surgeries like it was no big deal, and it was. Patient safety was completely depleted, and like I said, the biggest example, people coming in with no lab work. I'm just touching on what can happen with understaffing. We all desperately need legislation. My local spent the last year, there was some legislation that was going forward for safe staffing. I know you all have been trying to get something through with cyber security. These things are imperative because no one is accountable. These are people's lives whose lives are at stake. I want you to consider what this can do to communities that have multiple hospitals. Our friend Dr. Dameff states that these cyber attacks can cause our neighboring hospitals to be seriously overburdened. And thank you for that research. That was awesome. So today, what I'm doing, I brought we're trying to get contract language, and it's Appendix C, our cybersecurity contract language, to fight for this to be in there. So if this occurs again, I have something to stand on top of. I mean, and we're one of the only unions who had pandemic language. The women that I started out with in the union were thoughtful enough to throw in one line, and it saved me. So people think, oh, it's not going to happen again. At Ascension, there's a large plaza right next to it, and the vice president of that, who's under me, had gone in there either for food or for a doctor appointment. There's a lot of little offices in there. And she said, it was week 2 of 5 weeks. She said people already thought it was over. Oh, it's over, right? I feel like we're kind of a fast food society. We take in what the initial input from the media is, and then it gets forgotten. And I think people aren't aware of that. Downtime paperwork has not even been redone. It was so outdated. I was talking with Christian about it's got like drugs that aren't even used anymore on it, and wrong dosages. I love that the Josh Cormans and Christian Dameffs and Beaus are fighting for legislature and bringing this all to light, because it's a dirty secret the hospital holds on to. But I have a big suspicion that if faced with a big fine for not being prepared or doing the right thing, or training the healthcare workers, doing their due diligence with making our computer systems safe for the healthcare workers and most of our patients, I believe they will roll the dice and wait and see if another disaster strikes. There is no accountability. We never give up. There's no one riding in on a white horse to save us. That's why, as a union, we band together. We're fighting for legislation to keep our patients safe. And it's a good fight. I'm all in it. And with my over 1,000 healthcare workers, I'm going to fight until we figure this out. I want to thank you so much for listening, and thank you. I'm honored to be here.
Good job. That's a lot of brave things to say, and a story that, as difficult as it is to hear secondhand, imagine living it for 5 weeks. Showing up every day and working a 12-hour shift and being faced with all of those struggles of taking care of those patients, knowing that even on your best day, it's still risky to take care of patients. And then to have all of that completely taken away from you and having to navigate all that danger and all that peril and all that risk, now leveled up by 20, just because of how bad these attacks were. It is, that's a heavy thing. I don't know if it's gonna get much lighter, folks. So if anyone needs to start drinking, just kidding, I'm a doctor, you're not supposed to do that. We're gonna kind of continue a little bit with this, but I think in some ways, shift gears to what we've had is what it's like to operate on the technology side of a hospital system, the constraints, the troubles with budgets, some of these medical device issues, that intersection. And then we've had a firsthand account of what it's like to take care of patients during the heart of a ransomware attack, and talk about that from a individual patient level to a unit level to a hospital level to a regional level. So I'm going to spend the next little bit of is kind of doing a little bit of a recap, and then bringing 2 new things for you folks this year. And the focus for my remarks, again, are going to be a little bit more on the national scale or whatever. So I'm Quaddy. That's what everyone calls me during the summer cons. That's my handle. I've been coming to DEF CON and the summer cons for like over 25 years now. And so it's weird when people call me by my real name, but you call me whatever you want. I'm an associate professor of emergency medicine, biomedical informatics, and computer science. I just made associate. Woo!
Right.
Yep. I'm tenured now. They can't fire me. Just kidding. They can fire you. I found that out. Please don't fire me, boss. And I co-direct the Center for Healthcare Cybersecurity, UCA San Diego. We're almost 2 years now on this mission of kind of an academic healthcare cybersecurity research center. We're going to talk about some of that work. I just want to say thanks for you folks for what you brought and just the amazing bravery it takes to talk about something like this. But I bet some of you in the audience are like, wow, what did I get myself into? I saw a lot of heads like nodding. I bet you folks are the ones that work in healthcare or have people, like you get this. But I think some of you folks are probably like, is it really that bad? Like, what did I get myself into? What a mess. This map's going to come back later on. But I've been doing this with Beau and Josh and all these folks in this community. It's great to see so many familiar faces with, for a while now, like over 10 years. And it's allowed me a chance to, I think, take a step back and try to, from hearing these stories of what's happened with Ascension or Change or all these like gigantic attacks, it really causes you to think about how big the scale of this problem is, and how if we're really going to be addressing some of these issues, we're going to need fundamental change in the way we think about this problem, study it, and the solutions that we implement for it. And that even if we're so fortunate to solve it at one hospital, this is an unsolvable problem, like cybersecurity concerns in a hospital, we're never going to solve this problem. But even if we get really good at one hospital, there are over 6,000 in the United States alone, right? So it is a daunting challenge, a never-ending battle. But I think about this picture, and it'll make sense a little bit later, about really how much we need you folks to step up. And so I hope at the end to, again, instill that charge in you to kind of join us. I'm going to do a quick recap of last year, just because I think it has some stuff that's been mentioned and alluded to. We'll go real quick through this, and just so I know how many people I'm going to board that. Who was here last year for my talk? Okay, well, not that. I'm sorry, but hopefully this will be. I'm just going to go through the takeaways real quick and build upon what the other folks have said. Takeaway one was that we are critically dependent on connected technology, right? So how much did we hear about how much the nurses were needing the electronic health record and the pharmacy and these Pyxis Omnicells? Like, you cannot deliver even the basic standard of medical care in the United States without a huge amount of technology, whether that be connected medical devices, servers, all the way up to like operational technology, email, communication software, VoIP phone lines in a hospital. All of these technologies are critical for the timely care of patients. So it's amazing it works just normally, but let alone while we're under attack. But lesson one, we cannot deliver safe, high quality care in any hospital without technology. And to exemplify that, I talked last year about a study that just says like they followed some doctors around. I'm sure it would be even more so for nurses, and just counted how many clicks they used to execute their job every day. And it was tens of thousands, right? Like, I'm sorry, it was thousands of clicks. It's probably even more now. On just a regular shift in the hospital, a doctor or nurse is making thousands of clicks on a screen to deliver their job, or to actually accomplish their job. Takeaway two, healthcare attacks are rising. This is some great work from Dr. Naprash out of University of Minnesota. An update to this study is coming up, I've heard. It just talked about year after year. The threats are not decreasing. The frequency is increasing, and the severity of them. It's not ransomware lasting a day or two anymore. Like we all know, these are such devastating attacks, and the recovery is so complicated that we're talking about weeks to months. You were saying 1, 5. I don't think some people recognize in the audience that she was talking about weeks of downtime. That's huge. Oops. We've been having a lot of, lately, some contemporary large-scale failures with third-party stuff. So not even ransomware specifically getting hacked, but whatever critical third-party vendors that health infrastructure has will get attacked. Change Healthcare is a really good example of that, where a single ransomware attack on a third-party vendor impacted thousands of clinical operations, like small clinics, to hospital systems. And by impacted, what did I mean? It means it financially devastated many of these. There have been clinics, private practices, et cetera, that have closed because a vendor they used to process insurance reimbursements got ransomed. That's how fine a line so many of these organizations are really treading. Like, they are on the razor thin margin. Most of the time, they're lucky if they break a 1% margin of profit year after year. Now, I'm not saying hospitals should make a profit, but what I'm saying is that if you're always on that financial edge of a razor, these types of attacks that you're not even responsible for, that impact a vendor, could cause you to go out of business. And then what happens to the community around it if that hospital that goes out is the only hospital within 150 miles? Like, that's huge. It has cascading, rippling effects that last way longer than just the downtime of a single ransomware attack. Takeaway 3, cyber attacks impact these technologies and cause patient harms. I feel like we're getting, I was talking about Beau and Josh, like, we're getting old. Remember, like, a long time ago when we were like, we don't have studies that show patient harm. We get this constant feedback from, like, you're scaring people. There's no data that says that this happens, but I think that's changed. I think that it is hard to make the claim nowadays that cyber attacks, like ransomware attacks, do not impact patients. And I think one of the papers, I was talked about a little bit ago, if you're interested in this, it's an open access paper, you can go review it. But we just measured what happened around a hospital system that got ransomed at hospitals that didn't get ransomed. So think about it like an ecosystem. If you're in a city and there's 5 hospitals, if 3 of those get ransomed because of the same hospital system, those other 2 hospitals, they don't just continue on their merry way. They take a lot of the rippling ecosystem effects. They get overwhelmed. So everyone suffers in a community when ransomware happens. And we looked at what happened to emergency patients. Their care was impacted. They waited longer. They took longer to get admitted to the hospital. They left sooner than they were supposed to against medical advice at higher rates. Like, a lot of patients in the emergency department at a hospital that wasn't even ransomed were impacted. Ambulances were significantly impacted. The whole system of pre-hospital care, this is a graph that just shows the middle there is what happened during the ransomware attack, and it just shows the cumulative number of hours that hospitals are on diversion. And diversion, there's tons of papers to show that diversion is not good. If it takes longer for you to get to a hospital for care, if it takes longer for an ambulance to arrive at your home when you're having an emergency and then transport you to a hospital where you can get definitive care, that delay can kill people. And so ransomware attacks in communities impact even the ambulance systems. And then that video I thought was great. It talked about time-sensitive medical conditions like heart attacks, strokes, and things. And when you look at these types of really vulnerable patient populations where, like, minutes matter, hours matter, these patients can be disproportionately affected. And then this is a study we followed up with that just said, like, listen, if you have cardiac arrest, if your heart stops and they gotta do CPR on you and they gotta shock you, all that stuff you see on TV, and you're getting cared for in a hospital in a town where ransomware is happening, you have a 10-fold decrease in your survivability with favorable neurologic outcome, just because there's a ransomware attack in your town. That means that you, your loved one, your parents, whatever it's gonna be, have a 10-fold decrease in whether or not they're gonna survive and be able to feed themselves after a heart attack, after cardiac arrest, just because ransomware is in their town. This body of evidence that these types of things have impact well beyond the very obvious. Rippling effects, diversion, complications in care, medication errors. We're building more of a literature base to show that. Takeaway 4, hospitals are closing or consolidating, okay? So I think Ascension's a good example. They had 140 hospitals go out with their ransomware attack.
Yes.
This is only gonna get worse because healthcare is in such bad state financially in this country, and it's so disparately funded. That means we have financially well-off hospitals and we have poor hospitals. When the poor hospitals no longer can pay their bills and they want to close, they get absorbed by a larger healthcare system. So we're just getting fewer and fewer independently owned and operated hospitals. Now we're getting mega hospital systems where, like Ascension, 140 hospitals are on a single IT stack, which means if they have a ransomware attack, that effect cascades to all of the systems that are on a unified platform. And that's just accelerating. Hospitals are closing, they're getting acquired, we're consolidating healthcare, and at the end of the day, we're increasing our risk for catastrophic failures across the country. And rural healthcare is particularly at risk. There's a list that got published a couple months ago that talks that there are like imminently 300 hospitals, rural and critical access hospitals in this country. They're at the brink of closure right now. Like that list is going to grow. All right, takeaway 5, we're critically dependent on other critical infrastructure. I alluded to this, it's been great and also terrifying to hear how much an understanding I've had just learning about how critically dependent healthcare is on water, electricity, these types of interdependencies on critical infrastructure that are shared among critical infrastructure is terrifying. And then now we're going to go on to some of the newer stuff. So the last takeaway from last year was that, like, these problems are hard to fix quickly. And I made this analogy last year, and I think it still kind of holds, wherein a lot of what we talk about is about prevention, and we want to prevent ransomware attacks, right? But like, we don't just try to prevent heart attacks and cardiac arrest, right? These are the things that I'm supposed to tell you as your doctor. I'm not your doctor. As a doctor, you're not supposed to do, right? Like, don't smoke, don't get old, I guess. Don't drink, don't eat a lot of unhealthy food like I eat, right? Like stress, diabetes, these are things that can put you at higher risk for heart disease, right? We're supposed to not do these things. If you try to adhere to these recommendations, then your chance of something goes down less. We do that in cyber, like MFA, no shared passwords, network segmentation. We could go over like all of the specific recommendations on how you're going to try to make your hospital system more resilient. You're going to do the good stuff to try to prevent the attacks. And we spend, in my opinion, a lot of effort on the prevention. And that's ideal. We never want to have a ransomware attack hit a hospital. But how much are we really preparing for the inevitable when it does happen? Would you think if hospitals never actually had treatment for people who had heart attacks, we just spent all of our time in prevention? That's probably not a winning strategy. What's the right ratio? Do we spend 80% with prevention, 20% with response? Like, what do we do? And there's like these risk factors. I talked about all the things that are against us, but what is the kind of CPR, if you will? What's the treatment for when a healthcare system gets ransomed? Other than just recover as quick as you can. Try to do your best. Try to go on downtime, paperwork, and the young doctors that don't know how, they know TikTok, but they don't know how to do prescription writing. And I have to confess, like, I think I've handwritten prescriptions like 10 times total in my career. I'm sorry.
Now it's
No, not old. No. But what is the acute response to these types of things? And that's what I left on with last year. I alluded to this thing we're doing called the Healthcare Ransomware Resiliency and Response Program. And I got a couple things to show you guys today. And so we're very thankful we're funded out of the Advanced Research Project Agency for Health. It's kind of like DARPA, but for healthcare. And they took a chance on our pitch, which was exactly this, like, how are we going to respond to ransomware attacks in hospitals that can make patients safer? So this is like a 2-year research sprint, and we're almost done, and I got some stuff to show you. Thanks a lot to ARPA-H. The NIH would never fund this. The National Science Foundation would never fund this. I'm an academic, so I got to get my grant funding from the feds. And this type of stuff would never have been funded, so we're thankful for ARPA-H. They don't pay me to say this. I just am very thankful for these folks. All right, so I'm going to just stop and say, listen, the goal of this is to say, how do we rapidly identify ransomware attacks in critical health infrastructure? How do we let the doctors and nurses how do we build resources for them to deal with this when right now they have no playbooks? Raise your hand if you work cyber for an organization and you have a ransomware playbook already figured out ahead of time. Raise your hand. Like, you're supposed to, right? Like, you're supposed to have a guidebook for your technical response. We're gonna do forensics, we're gonna look at IOCs, we're gonna do this. You have a technical playbook, but the nurses on the cardiology wing, on telemetry, don't have a guidebook for how they take care of patients during a cyber attack. They just don't. So we aim to do that. I'm not gonna show you that work today, but that's the second part of this work. And then the third is this thing we call like a crash cart system. Like, how do a hospital's been ransomed, what do I need to bring to a hospital to get them off of paper? And how can we rapidly deploy that within hours of a ransomware attack so that doctors and nurses can take care of patients to the standard of care that the patients deserve and the clinicians are capable of doing? So it's not just me. We have a gigantic team of folks We have a bunch of really smart computer scientists, graduate students, and I gotta say, like, these folks work every single day on this project. So I'm gonna show you some of that work, but please, like, if you ever see these folks, buy them a beverage or something like that. They've been working tirelessly on this for what has been a really crazy sprint for the last 2 years. So there are 3 technical areas. They have little pithy code names. We're gonna probably have to change some of these names. But right now, these are just kind of our research project code names. We're not gonna talk about the tome today. The first thing I'm gonna talk about is this thing we call ransomware. And it was this question that was really frustrating to me as a researcher. It got born out of the problems we had, Beau and Josh, about like, hey, where's the data that shows what hospitals have been ransomed? Like, what's the data about how long they were down for? What's the data about what the patient adverse effects were? It didn't exist because when a hospital system gets ransomed, they don't want to talk about it. Their PR teams say, shut up. If you talk to the media, we'll fire you. And I'm not, Liz, it's complicated. Why do they do that? It's because they are already under attack. They have these risks that they don't understand fully. They don't know how long it's going to be about. They have a lot of unanswered questions. And their default position is to like not talk about it. They don't want to invite subsequent lawsuits. They don't want to have any more brand reputational damage, et cetera, et cetera, et cetera. But those are reasons why they say don't talk about it. So I can't, as a researcher, go up to them and be like, hey, will you give me all of your data about this? And be like, no, thank you. I'm like, sir, this is a Wendy's. Get out of here. So I was really frustrated by this. So I had this question, this idea, like, well, can we figure out if hospitals have been ransomed without them ever having to tell us, without having to find out about it on the news? So we did that. We built a system we call ransomware. It's like an academic project where we have a prototype system that scans over 6,000 hospitals hourly. We've spent the last year and a half reverse engineering the public surface of every hospital system in this country and have a really good understanding of like what services they're all running and all of this stuff. And we have been scanning it for over a year. And we've amassed a gigantic data set. Over 6,000 hospitals, we know. And we've been, kind of looks like this, right? Little dashboard, little red dots saying, oh, stuff's down, little yellow dots, some stuff's down, green dots, everything's cool, right? And so we've been collecting this data, and we've been successful in identifying 3 instances of ransomware attacks we detected on our system before it was ever publicly available. So anyone here from Chi-Town, Chicago? I like your pizza. I know people from New York hate it, but I love it. We detected Lurie Children's Hospital when they got ransomed earlier this year, before they publicly announced it. Our system saw a bunch of their stuff drop off. And we've had this benefit of scanning at a nearly hour. We initially were scanning every 6 hours, every 3 hours, but now our frequency is every hour. But we have like longitudinal data about all of these services and when it's up and down. And we've been measuring it. Now I'm gonna show you guys a study we just published. I have some important caveats I have to say ahead of time. Number one is science is messy. It's also sometimes controversial. So I'm gonna show you this paper and you can read it yourself. I have to put out some disclaimers ahead of time, which is I'm gonna show you association data. Does anyone can quickly explain to me what an association is in research? Like something is associated with something else. Raise your hand if you wanna quickly take a stab at it. Yes?
Who pays for it?
Ah, that's a different type of association. But that's a funny, I like that. All we know is that 2 things kind of temporally or spatially or something happened at about the same time. Okay, so I'm gonna show you, it does not show causal data. I cannot tell you with certainty X caused Y. I can say X and Y happened at the same time, and I can show you the data, and you can ask yourself what you think happened, all right? Number 2, this is one of what happens when I want to do is lots of studies about this type of stuff. So it doesn't answer every question you're going to have. So we had this system running for about a year. We were seeing evidence of ransomware attacks. It was pretty cool because we could also see how long they were down for. We could see what services they brought up first. Oh, their email servers came up first. Or hey, their their ServiceNow came up first. That makes sense. They bring up ServiceNow first because they can do all the tickets for what needs to happen on the response. Like, we saw these hospitals recovering as well, and it gave us a lot of tremendous insight. We had the system running. And then something happened a little bit over a year ago. Does anyone remember what happened before DEF CON about a year ago in the news? I'm sorry? Yeah, CrowdStrike happened. So I know I'm going to tell you, if you want this QR code, you're going to have to trust me. This goes to this study. We published this last year, and I'm talking about association data. I'm going to show you some stuff. I really encourage you to read this paper. And I also encourage you to read the limitations section of this paper about what this paper does and does not. And then if you have any methodology questions, you can ask me. But I ask you to read the paper first because it talks about a lot about how we did this and what our data was. All right? So the question I had is, what did we see go down around CrowdStrike? I can't tell you that CrowdStrike caused this. I can say I know what we had seen prior to CrowdStrike, what happened during CrowdStrike, and what happened after CrowdStrike, and I can tell you what I saw go down. So the question is, what patient care outcomes or technology outages were associated with CrowdStrike? There was also a Azure outage that day, I've been told, so maybe it was that as part of it. But we actually did 2,200 hospitals in this data set. And we looked at, again, before, during, and after a CrowdStrike outage. This was not an attack. This was not a ransomware attack. This was not a cyber incident. They had an outage. And we identified 759 hospitals that had outages occurring associated at the same time as CrowdStrike. So we saw 759 hospitals have some outages right during CrowdStrike. And then we went and looked at every single one of those and what services were available before, during, and after, and tried to characterize every single one of those services and say, were they ones that take care of patients? Were they ones that help the enterprise? Or we were not able to identify? I think this graph speaks for itself. Some people want to say that, how did you know that they didn't do a firewall configuration, or that they didn't do like an update, or that something else? So this graph shows daily the number of, there's a technology, an API standard called FHIR, Fast Healthcare Interoperability Resource. This is a healthcare specific kind of API standard that lets your hospital share your records with a bunch of apps and other providers. So this FHIR endpoints is what we call it. We have been monitoring FHIR endpoints for over a year. On average, we see 5, 8 go down on a daily basis of the hundreds that we measure, thousands that we measure a day. At that orange line, that's when CrowdStrike outage happened, and you can see an associated huge spike in these FHIR endpoints that went down. These are healthcare delivery organizations, not individual hospitals. And then we looked at all of our IP data, not just our FHIR endpoint data. We went and looked at, again, all of our IP scanning data. And we saw, these are the hospitals that had downtimes associated at the same time temporally as CrowdStrike. And we have the duration. We know when they were up and when they were down. And again, we're not scanning every minute, so I don't have minute granularity, but we have like hour granularity for most of this stuff. And then we went and looked at every single service of that outage, and we categorized them into 4 buckets. One was patient-facing stuff. We saw, prior to CrowdStrike we saw things like EMS ambulance dispatch software. There's software that allows a ambulance to communicate patient information to a hospital. That was one of the services that we saw go down. We saw a whole bunch of patient portals go down, so you couldn't access your patient records. We saw a whole bunch of other kind of clinically focused stuff, and that was about 22% of all the stuff we saw go down associated with CrowdStrike was patient-facing. Then we had about 15.5%, 15.4% of it be operationally relevant. These are things like email servers going down or ServiceNow portals going down, these types of things that matter to the healthcare delivery but aren't necessarily directly focused at taking care of patients. We saw a bunch of research stuff go down. We saw about 5% of what went down had to do with like recruiting patients for studies or educating patients on clinical studies for new drugs and trials and things like that. And then about 57% of the time, we couldn't tell what this particular thing was. So we just put it in this unknown or not relevant bucket. And I think this kind of shows a couple things. One, that a single issue could maybe cascade is associated with this like really large healthcare disruption that we saw. But how many of those are there out there? If you would have asked me, I'm gonna be honest, if you had asked me if I would have thought CrowdStrike would have had an outage like that a year and a half ago, I would never have thought it would have happened. I would never have thought that would have occurred at the scale it did. But it did. My question, and what happened was significant. It wasn't just healthcare. You guys saw airline industry, all these other things happen. How many different systems it impacted? My question is, how many analogous dependent third-party vendors that are critical for the delivery of healthcare are there out there that we don't even know? We have no idea. Like if there's an O365 outage, how many hospital and trauma centers are going to completely collapse, right? If there's an Azure outage, or if there's an Amazon EC, like how much stuff is hosted, critical healthcare stuff that's hosted in the cloud? Change is a great example. I talked about that before. If you think someone knows those linchpins, those digital linchpins in healthcare infrastructure in this country, you are wrong. And I have not seen a single person that can coherently explain to you the scope of the risk. No one knows how many of these are out there. No one's mapped it. So it's a kind of scary thing. The other thing I would say that this speaks to a little bit is, again, just how critically dependent healthcare is on these types of third-party vendors. So that's the first thing I want to show you guys. And if you're interested, you can read the paper and the limitations section. I'm looking at you. All right. Next. Rapidly, we're going to talk about the next project, which is this like, hey, what's the CPR for a hospital that's been ransomed? And the question is, like, what would you need to bring to a hospital that's been ransomed to like get them off of paper? Like, what would you have to give the nursing staff and the doctors and the technicians and the registration folks and the phlebotomists? Like, what could you put in the back of an 18-wheeler, drive to their facility, and deploy within 2 hours to say, hey, you're not going to be down for 5 weeks? Or you might be down for 5 weeks with your own systems, but we brought this other thing. And you can work on at least this somewhat better system until you can recover. I have questions like, that's a scientific and a usability question, right? Like, what do you actually need to bring and how would you engineer it? That's what we sought to do with what we call Crash Cart, disaster recovery Crash Cart. And we spent the last year and a half building a prototype of it. And it fits in the back of a 9-foot van, and it's scoped to try to restore the technology of a 20-bed emergency department. We're not anywhere near being able to do it for a whole hospital. But we're like prototyping this for like, hey, the emergency department needs to function. We need to deliver patient care. If anyone has a heart attack or a stroke or gets stabbed, what do we need to bring to basically do it? And that's what we scoped it at. And so the other interesting engineering challenge for this is like, you have to build this into an entire, you have significant engineering challenges because you are going to set up this replacement system right next to a hostile network that has active malware. So we can't touch any of their switches. We can't use any of their existing infrastructure. We can't use any of their existing spectrum because they're going to be bringing up their own Wi-Fi, right? So we have to operate on a different spectrum. We can't use their backhaul internet. They won't let us touch their fiber because they're worried about data exfil, right? They're worried about command and control. So they'll cut their backhaul as part of their ransomware response. So you have to bring your own internet. You have to bring your own spectrum. You have to bring your own endpoint devices, your own electronic health record, your own laboratory devices. You have to be able to quickly integrate with their own CT scanners and their ultrasounds and all that stuff. And you have to bring all that infrastructure in a mobile set. And that's what we did, and we call it Crash Cart. And so some of the stuff I'm going to highlight here is like, we use Starlink as our internet backhaul. And we co-aggregate a bunch of 5G. So we have a system where we can basically bond every commercial cellular provider in an area and then bond that also with the Starlink backhaul to get, we've achieved some pretty significant bandwidth throughputs to try to support the system. But is that going to be the same bandwidth that we're going to have in rural Idaho, rural Nebraska, downtown Manhattan? I mean, these are constraints that we have to make the system available anywhere in the world. We spin up our own private 4G, 5G network. We don't use Wi-Fi. I told you, it can't compete on their spectrum. So we actually we run our own private little cellular towers, our own little cellular access points, and we run all of our endpoints and all that stuff on cellular. It's not an air gap. I'm not stupid enough to say that. But I'm trying to say is like, they're going to be infected on their endpoints. They're going to have, we can't touch their APs and all their stuff, but we spin up our own things and run everything over cellular, private cellular. We bring our own laboratory devices. We bring our own endpoints that are hardened. We bring our own monitoring system so that we can monitor patients if they deteriorate. We can't use their existing stuff. And so I'm happy to announce that we deployed this not during an active ransomware attack, but about 2 weeks ago, we went out to a small hospital in the Imperial Desert. It was 110 degrees with our U-Haul van. And we deployed this in we had done this in the lab, we had done this in our SIM center, but this is the first time we deployed it in a real hospital system. So we brought it, we set it up. It took us 39 minutes from the time we opened the back of the truck to when we had a functioning electronic health record, our private 5G network, and all of our endpoints booted, all that stuff. It took us 39 minutes. We print our own labels, our armbands, this stuff. And like, what is this? Like, this is proof of concept for a different way to approach the problem. We can spend a ton of money trying to prevent stuff from happening, but we don't have a plan clinically for when it does happen. And the question I have is like, if we had this and we scaled it and it was a national resource, like if we had that type of stuff available, would hospitals pay ransoms? Would ransomware operators go and attack them because they know, hey, there's a backup system we can rapidly deploy within hours of response that, can we bend the arc of ransomware economics with something like this? Hey, this healthcare is a complicated example. You got to do labs and imaging and all that stuff. But can you apply this to other verticals that get ransomed as well? Like the idea that can we take the sting or burn out of ransomware enough with something like this that we can hopefully try to prevent them attacks in the longer term is kind of the goal. And so I'm like really happy to talk to you guys about this. I mean, I know there's going to be a lot of questions maybe or like flaws in our logic, and we welcome them all. But it's been like a whirlwind 2 years that we've had building ransomware, building Crash Cart, testing this stuff. And what we need are folks to like help us make it better, because I think our patients deserve it. And like, you're going to be a patient one day. I think you deserve it. That's it.
Great job.
All right.
Alrighty, so
I'll do Dave's job while he's getting the mic turned on. We have a microphone over here. We have 38 minutes for questions. We've got 2.5 smart people who are ready to field them. Got one question ready to go.
Dina, if you have it handy, one of the things I had socialized to people is you had a demand letter of 5 things that you felt would equip the nursing staff to maintain the quality of care and the communication. Could you maybe enumerate those 5 while people are lining up?
I did throw it in my presentation, but
Move
yes.
the microphone.
Yes.
And by the way, I loved them. We hadn't even spoken or met yet. And I think arguably this room could maybe add to and refine these for intent. But already on their own, they're pretty impressive.
Well, we threw them in a cyber attack appendix for the contract. We altered it. I kind of like our article, even if we improved upon it. If there is a declaration of an authentic, and I'm telling you, they don't want to say cyber attack. We had to cross it out. Authentic electronic operational failure. Bargaining unit RNs will not be required to take any more than 50% of the patient load assignment as designated by the CBA staffing matrix. So I felt like that was an improvement on the 1 to 4 at the time. Like we just did that for the bigger units. The immediate recruitment of service group ancillary staff through a letter of understanding is crucial to alleviating the burdens placed on our RNs, ensuring that patient safety is not compromised. It's essential that when calls for additional staffing need to be communicated in a timely manner within 8 hours of the start of the shift for a successful response. We added daily meeting times as we did in the petition. We put in daily unit shift huddles, weekly huddles with the union and HR addressing all the issues going on in the house. Alternate measures of communication. One thing I didn't say that was mildly enjoyable, the VP of HR had to come to me because my text blast and email blast, they could not communicate with the registered nurses in the service group. So they came to me and said, will you please send our emails? And there was some mild enjoyment of that. Just saying. So anyway, that was what I felt like we improved on it in our contract language.
I might be misremembering this, but a follow-up. Did you ask for simulations and trainings like fire?
Yes, we did. And
Save us a question.
we asked also for training for these cyber attacks because no one's ready. I sent Joshua a picture the other day. In the corner in my unit was a big stack of like just thrown together papers that we're supposed to figure out if there's some downtime issues. So it's just incredible. But it's profits over patience. So thank you.
Hi, Dr. Dameff. Thank you so much for your display of Crash Cart. I've been excitedly waiting for Crash Cart because I got $40,000 waiting with your name on it, basically for Crash Cart for my community. Do you know when you'll be releasing any of the information or the data from that? Because I really want like the equipment list or the training list that you've been developing.
Yeah, we just finished writing a paper and submitted it to a journal, so hopefully it gets accepted, and then it'll be available for the whole world. Our 2-year sprint with ARPA-H for the research funding is supposed to end in September. And so we have a couple extra like large scale deployments we have to do, some more proof of concept kind of integrations with some of the clinical tech, but we're kicking the tires at the end of the prototype now. And now it's going to be about scaling, right? So it's like, I think there are a lot of unanswered questions. Like hospital systems probably not going to be able to buy their own crash cart and keep it in their, like build their own crash cart and keep it in their basement for when they need it. So like we have these questions about like, well, should it be deployed as a critical national resource? Like we do this thing called the Strategic National Stockpile for drugs and vaccines and stuff that are like strategically positioned around the country. Do we need something similar for healthcare IT, right? Like do we have this around so that we're within 6 hours of any large area of people in hospitals that we could drive a truck there? Like there's these questions about how do we roll this out? And then there's questions about scale. Our prototype fits in the, like, it's almost like 60% of a back of a 9-foot truck. But if we were to do that for a whole hospital, it's gonna be much bigger. It's good. Each individual parts of the hospital are gonna have unique considerations. Like the ICU is gonna need different stuff than like your family practice office across the street. So scaling this to be able to say, could we roll into a hospital and replace an entire 200-bed hospital's total stack? There's a lot of more work that has to do with the scaling of this. That doesn't answer your question, but what I'm trying to get at is, right now, I think what we need to do is have people deploy this, do a test deployment in their area, and then say, have you considered this? Or what about this? Or, hey, we need to work on what do we, because right now during ransomware response, we throw the baby out the bathwater. So you get hit, your technical playbook says, cut off your backhaul, turn off all of your systems, and then do forensics, IOC. Like there is a technical rationale for why we do all this stuff. But what it does is it basically takes a system where we maybe could use 30% of it or 40% of it. You know, there are not many cases that are documented of CT scanners being primarily infected with ransomware. I'm aware of one. That means maybe it's the case that we can use your MRI machine and your CT scanners. We don't have to not use them during a ransomware attack or other clinical. So I'm just giving an example. But this work of like, what can we use safely in infrastructure that's been hit? What do we need? What assurances do we need before we can reliably use it? How do we do that quickly? These are all these questions and things that are still research questions that we need to do before this is ready for prime time. But in the meantime, we're going to get it out there, and we're going to have people kick the tires on it and make it better. Because this was our first swing at it, and we had to do it on a crazy timeline. Like we had 2 years from start to finish. And I've been pretty proud of what we've been doing, but we have a lot more to do.
Good job.
Just in a minor response, so I'm thinking the hospital preparedness, our healthcare coalition, and then maybe our public health emergency preparedness grant recipients might be able to fund these local implementations. And to your point, like that NDMS, right? It's like, can we deploy these mobile hospitals? Can we deploy these through the Arizona National Guard or other things like that? So yeah, thanks.
Yeah, great ideas.
One question, one analogy. I'll start with the analogy or story before. So there was a very small little hospital in, I figured it was a little small for me. In Los Angeles, Hollywood. I'm sure many of us have heard for it. It supports, very cool things and lots of important people. I was the incident commander for an event that occurred, and it started with basically somebody looking at x-rays, going to sites that they should not. Those devices were not really on the network. Those devices were vendor owned. Those devices were supposed to have a vendor managed antivirus. They did not. And so that went reasonably well. There was no actual impact to any other surrounding systems. Very localized. We did find it because ransomware artifacts started appearing on other domain systems like the domain controller, which started the panic attack on a Saturday morning. The sad thing is we actually had that same problem, the computer right next to it about 6 months later with the same, medical technician kind of doing the same thing, going to sites that they should not have. So obviously there's a whole aspect around vendor managed systems and everything else like that. And so you mentioned, like, I've never heard of CT machines and some of these others of, doing that. Like I actually have. It's exciting. And this was, just for clarity and everything else like that, over 10 years ago. So if that's helpful in terms of explaining that. My question is completely different. We talk a lot about the medical stuff and ER and everything else like that, but how does behavioral health have any impact on some of those things? Because we know, especially coming out of COVID, there's been this big push for behavioral health having just such an impact on our communities and everything else. Has there been anything around behavioral health being part of that emergency preparedness kind of conversation?
We have a really large ER in the hospital I work in, and we have a huge area for behavioral health. A very kind governor many years ago got rid of all our mental health services, like virtually most of them. So it's very hard to move these folks to the place they need to get to. We hold them for a horribly long time. The one good thing about their issues is they're not on a monitor, but their meds are of the utmost importance. So it's kind of the same as everyone else, medication-wise, because when you start messing up medication for someone who needs it for their mental health, it's even more, it's just as important as everything else. So I don't think anyone looks at anything differently. I mean, I think they package them in with all the other important things. But mental health, it's a crisis. It's terrible. Thank you.
Hello. New to the field. This is my first con talking about these sort of things. So thank you for the amazing work you do. The question I have is, with the crash cart, is there augmentations or overlaps into more national disaster situations, such as there's no power here, or something of that sort? What does that timeline or effectiveness look like from your perspective?
Yeah, great question. There's no reason you can't take crash cart and deploy it in like a gym at a high school. Other than our engineering constraints, we did not assume we'd have to bring our own power. We gamed it out. We could do it with a pretty readily available commercial generator that could run multi-fuel stuff. So to answer your question about, I don't know if I'm answering your question right, but crash cart has multiple potential applications other than ransomware. And we feel like that is one of the most challenging engineering cases for which, if it would work under that circumstance and we've solved some of those problems, then I think we've solved a lot of problems for some of these other things. Now, there are undoubtedly, I'm not a disaster medicine expert. I'm not an expert in earthquakes or floods or tornadoes or anything like that. I'm not going to pretend to be. But my feeling is that we're going to get a lot more applications from this. And that, I think, lends itself a little bit more to this model, like strategically positioning the stuff around. We do have some analogies for this in like military systems. They rapidly deploy field hospitals and these types of things already. So this is not an entirely new situation. But one of the things that we wanted to focus on is how do we leverage the existing people at an organization. So if you're like a FEMA team and you're responding to a hurricane, you bring your own doctors and nurses and you deploy your technology in a field hospital, but you are training your folks for that system and they know how to use it. It's an entirely different game when you have to use doctors and nurses and phlebotomists and registration folks on site. So one of the things that we've built the system around is to be modular in the types of things like electronic health record views. The idea would be we have, there are several flavors of electronic health records like Epic and Cerner and Allscripts and these other things. They constitute a majority of electronic health records. If you give a Cerner nurse Epic and they've never used Epic before, you might as well kill the patients then. You might as well just kill them right then.
It's true.
You give a cardiothoracic surgeon who thinks they're God Cerner and they're an Epic doctor, they'll kill you and they will not be prosecuted. What I'm trying to get at is these usability issues are really real. So how do you pre-position cloud infrastructure to be able to be modular in your deployment? You're a Cerner shop, we'll give you vanilla Cerner. So at least your doctors and nurses know how to use that. You might not have all your fancy bells and whistles and all the customization you had before, but at least you'll have the basics of usability. You'll know how to use it at an elementary level. You have to design a system that can, on the fly, deploy these different things, is another consideration to this. I don't know if this is all answer your question, but yeah. All right, sorry.
Question on the crash cart. For the 4G cell backend you have, are you using just consumer grade 4G or is it on is the 4G on the FirstNet, first responder networks, or just consumer?
Great question. So on if I misspoke, forgive me. Our internet backhaul is using Starlink bonded with, we have like a Cradlepoint router that will bond Verizon, T-Mobile, and AT&T FirstNet all into one signal. So there's the cellular backhaul side of that. And then we deploy private 5G on the CBRS spectrum in the hospital. So for folks that don't speak cellular, we basically spin up our own private cellular network in a hospital. So you look at your phone, you look at the top, it says T-Mobile or AT&T or whatever. When we have phones that we issue to folks in Crash Cart, on the top it says Crash Cart. It's our own private network. That's a separate cellular network that we deploy in the hospital. Why did we choose that? We couldn't use the spectrum that they were on, but two, I only have to deploy one AP, so it has much better penetrance in a hospital. I only have to deploy one of AP instead of like 5 or 6 Wi-Fi APs. So there were other reasons. We more quickly deploy that. Does that answer your question?
Yeah, thanks.
Yeah, FirstNet's been rad. Like, not the fastest, but definitely deployed in a lot of areas in the hospital, in the nation.
Hi. As an EMT and a cybersecurity engineer myself, I think the concept of the crash cart's really, really cool. And one of the things I wanted to ask about, it sounds like crash cart is going to be deployed during an incident. So what does kind of like the incident management process look like when you're working with the hospital?
Yeah, great question. Hey, I heard you've been ransomed. Can I drive an 18-wheeler up to it and deploy a bunch of crazy stuff in your hospital like within 4 hours? Is that cool? To be determined. My mental model for this is, anyone seen Field of Dreams? Come on, like, I'm getting old now, huh? Like, I have to say that and qualify it. Like, none of my med students I teach or my residents I teach have seen that damn movie, so I'm now getting old. Like, so many times I had this idea for Crash Cart, and I'd tell people, and they'd say it's too hard. So they wouldn't even, like, engage in the premise. Like, so I almost had to build it, and they will come. Like, I had to show that it was feasible before people would ever really wrestle with, well, how would we do that? And so I think if we can show technical feasibility, if we can show the benefit, if we can teach a hospital like, hey, you might lose $100 million on this ransomware attack. I mean, there have been documented cases of hospital systems losing over $100 million because of a ransomware attack.
There's been documented cases of hospitals being completely shut down from ransomware attacks, from losing all their funding, essentially.
So if we can get far enough with Crash Cart to be like, hey, this might be the difference between whether or not you shut down or whether or not between you lose $100 million or $50 million, then it might make those types of conversations a little bit easier. But there's still a lot of work that has to happen. We've built it, and now we have to see if they come and play baseball. So you guys are like, haven't seen this movie, or like, what the hell is this guy talking about? But anyways, build it and they will come, is the kind of faith, if you will, that we're having in this. But to answer your question, it'll probably depend a lot on the hospital system, the governor of the state, how it's actually deployed. Is this a commercial product? Is this a national resource? Is Congress going to fund this? Will impact a lot of what you're talking about.
Great.
Hope that answered your question.
It does. Thank you for all you guys do.
Yeah.
Hello. Okay. So first of all, love Crash Cart. I have two questions related to it. The first one, I'm not super familiar with like hospital network systems, architecture in general. So I'm assuming that there is like some difference between like those environments from hospital to hospital, right? So if you have like a prepackaged like Crash Cart kit, right? I'm curious about some of the considerations that you've taken in terms of like adaptability, right, from one hospital to the other. And I know you spoke a little bit about like the mobility, some of the flexibility you have with like modularity, right? But I'm curious more about like adaptability, like, hey, I have this kit, but maybe a specific vendor needs a specific tool or that kind of thing. So how you kind of took that into account. And then in terms of the kit, you know, I'm assuming like you don't have a ransomware attack like every week, hopefully not. But you know, in terms of like maintenance is one of the things that came to mind, right? Because you're gonna have like like the kit like kind of packaged up, probably sitting in the back just like ready to go. So like how much maintenance do you need to like keep that like going, you know, so that you can rely on it once you actually have to deploy it?
Yeah, that's the first question first, and just say like, yeah, clearly, however this gets implemented, they need folks like you thinking about the logistics, like, and the actual scalability of that stuff. Yeah, undoubtedly there's going to be a lot of operational and logistics part of this that are going to become even more important as it scales. So maintenance, we assume our system is going to be more secure than the standard hospital system, but that might not be the case. And I'll tell you, how embarrassing would it be if like we didn't patch the endpoints and like we get into the clinical environment and then like we get ransomed too. That would really suck. That have to just say I'm sorry at that point. But to your point, like you need a whole program around that.
Yeah.
And that's going to require like the organization of either like a dedicated unit, company, something is going to have to make sure that considerations like that are addressed, especially when talking about another thing, which is like the scalability problems. I told you Ascension's got 140 hospitals that got ransomed. You can't build 200 crash carts and have them ready to go. So like these catastrophic failures, crash cart might not be able to scale that quickly, especially when we see a single point of failure cascading to so many other hospitals. So to your first question, a lot of what we've done, and hopefully this comes out in the paper when it gets published, is like we had to figure out the question if we could use a cellular backhaul for hospitals. Well, the questions you have is, well, dang, 6,000 hospitals. How are you, if that's your critical backhaul for your internet, what's the cellular connectivity for most hospitals in this country? So we did a little mini study where we went to open source, like we used Wiggle. Anyone use Wiggle? Yeah. So we used Wiggle data to be like, here's every hospital in the country geolocated. What cell towers are around them and what services are around, like what providers. So we could say reliably, could we take crash cart to the middle of Nebraska at this hospital and have an internet backhaul? So we had to do experiments like that. We built a set of tools like, hey, you have to get, what if the ICU is on the 4th floor? And how do you get from your internet backhaul on the ground to like a system up on the 4th floor? So we've been experimenting a lot with like point-to-point Wi-Fi. We've been talking about building stuff to shoot through windows, like cellular connectivity, all this other stuff that I think to your point is not every hospital is the same. They're not built the same. They're not located in the same way. So what you really need to do is build a set of tools and techniques and a toolbox to be able to take it to a hospital, anyone, and say, all right, I have these things to help me accomplish this goal. And you're not just have one piece of technology that if it doesn't work, the whole thing doesn't work. Hope that answers your question.
Yeah.
A lot of open questions.
Yeah. Thank you.
I'm sorry about all the crash cart questions, guys.
I love
Please
this.
hop in.
I love it. I'm good.
Hi. So I am actually a dental hygienist, and I worked at an office that was a recipient of a ransomware attack, and that's kind of how I am now here, because I just was like, how did this happen? And so it's kind of my new passion, moving from the clinical aspect into the security aspect. But my question isn't super tech heavy, but I am curious about I keep seeing all these unions for nurses, doctors having to fight with companies in order to get proper staffing ratios, equipment that they need, basic things for patient safety. Do you see any path forward with any organizations or individual either senators or congressmen that we can apply pressure to that would enact statewide legislation that would help with those issues?
It may be 3.5 years before that happens again. Last year, not to be political, I love everyone. However, last year we were very, very close to getting some nurse to patient ratios passed in legislation, like at the Capitol. We're super excited. They're also talking about banning, mandating nurses. Because I'll tell you what, I'm almost 63, and you push me to 16 hours, I'd be a goner. So we were that close. However, my union banned, there's no mandation, so there's that. But we were trying, and then it died a horrible death in January. So we fight. We're not going to lay down and stop fighting, but that's exactly how you make the change. Because right now I have contract language that says they can't violate the staffing matrix, and if you do, you're going to pay a lot of money. They don't care. Someone else higher up needs to make them accountable. There's no accountability anywhere. So I hear you, sister.
Thank you.
But contact your representatives, contact everyone and tell them how much that means to you. Because all together we are in our solidarity fighting together.
I think the crash card idea is a really interesting idea. One question I have is on like the data piece of it. So you're talking about like EHR systems, getting those working, but the value there is in the data that's in the system. So Epic or something like that. So how would that work in theory, like to populate the crash cart system with the data? Would hospitals really need to start thinking about, can we localize our data? Can we have backups of our data so that in a crisis we can populate this new system? And my sense is, as with most other organizations, it's very siloed now based on vendors and their application and their cloud infrastructure. So hospitals probably don't have or own that data. And so how do you solve that problem?
Yeah, that's a really great question. So I think I'll handle it in two parts. There's value of the electronic health record outside the data. So if you folks are familiar with this, we keep talking about the electronic health record. We talk about things like Epic and Cerner and these things. I cannot express to you significantly enough how critical that piece of software is for healthcare. You can't do anything without the electronic health record. It is a phenomenal repository of data, but you also can't order medications without it. You also can't order imaging. You can't, nowadays we're using it to communicate with staff. We send messages in the electronic health record to nurses and other doctors to do tasks. It is such a monolithic, critical piece of technology that if we just deployed CrashCart with a vanilla, there are no patients' data in there, you're going to register every patient again, and you could do that. And then you get the value of an electronic health record without the value of the data. So that's one. So even if we didn't get the integration or the backup integrated into the system, there's still potentially value there. Two, hospitals are increasingly hosting their electronic health records in the cloud. So Cerner got bought by Oracle. Epic has been increasing their percentage of their customers that are hosting in their data centers. Now, we could talk about how terrifying that is for me. I'm not going to get into that part right now. But there is a situation where we could hook up CrashCart to their existing cloud infrastructure. Now, there are security bugaboos with that. Don't get me wrong.
Yeah.
I mean, you've been compromised. You might share AD. Are you going to flush all those credentials? How are you going to handle all that? That is definitely still some considerations. But the model I have is like, if we can hook you up to your existing cloud infrastructure with CrashCart, and we can handle these concerns about AD, maybe go to manual physical authentication alternatives, et cetera, then cool. Or if we can't, and you just have to get it vanilla from the start, re-register all your patients in a brand new system, and then we'll integrate it afterwards after you get your system up, we might be able to do that. So there are different ways that we can approach it. The devil's in the details. And so how Epic does things and how Cerner does things is completely different. But I do think the last part also a bit, if we have a system and we give them clear instructions on how they could back up their master patient index, and then how we could integrate it quickly, we could actually have hospitals preparing a little bit to integrate in a CrashCart ahead of time, which will also have added benefits of they actually will have like a secure backup of their patient health record that independent of CrashCart they should have anyways.
Right, because what Change showed us, right, is Epic could be the target in addition to the hospital, right, or CERN or whatever. I mean, you're assuming those are available, but they may not be. They may have been involved in the same incident that took out your local network.
Yeah. You're trying to give me nightmares.
I don't handle microphones often, so anyway. So first of all, I have a kind of experiential and anecdote. So my local hospital experienced a ransomware or cyber event, I'm not sure. And I had a potential aggressive cancer scare during that event. And so my experience was they wanted to get me into a special facility to actually look into it, but then that message didn't get passed along. And so 2 weeks later, my doctor's going, "Did you go?" And I'm like, "I never got." So it was just kind of this potential perilous moment of just what's happening. So but I appreciated your experience as a nurse because I understood when I'm in there in the office and they're all operating on paper is their world is chaos. And so I was just kind of you have no idea what I do for a living. I understand, but I didn't fully. So I appreciated your perspective. So from the CrashCart perspective is how do you know what equipment you have to have or, what specialists you have to have? And I don't necessarily expect you to answer that. It's just kind of from that perspective of that experience that I had, I was wondering, are you going to have that particular specialist to look for my potentially aggressive cancer, in that moment? Probably not. I don't know. But anyway, my other question was about HIPAA, and it's I started my thought process when you were talking, but I feel like HIPAA kind of hurts us in the cybersecurity protection of healthcare organizations. A lot of my clients are healthcare organizations that have experienced ransomware events. And so contingency planning is obviously what is that? It seems to be kind of the experience. But I don't think that, HIPAA requires it, contingency planning. They expect you to have that in place. But there's no it's a compliance checkbox. There's no do you have all of the staffing needs that you have? And I'm over here wondering, do I need to be asking those questions? Do I need to be asking them, are you preparing in your contingency planning for staffing? So now, thanks for that. My clients will either be happy or very unhappy with that experience. But, is HIPAA helping is kind of my question, because I think that they want to pay the fine as opposed to staff or something along those lines. But for those smaller organizations, which are a lot of my clients, you talked about them going out of business or closing as a result of these events. Is it because of the HIPAA breach fine impact that they're closing? Could we be preserving those rural organizations that we need, their critical infrastructure, right? Could we be preserving them by avoiding those fines and actually providing them some cybersecurity assistance? So that's kind of a question, if you guys have thought about that or anything. So.
I think there was one about CrashCart, one about HIPAA. Do you want to take the CrashCart? I'll take the HIPAA.
Sure. Can you remind me real quick, the CrashCart question was how do you So if I understand correctly,
Specialists and
your
special
referral
equipment.
didn't get sent. It sounds like they wanted to send you to another
A specialist.
specialist.
Yeah. An
And that
organization
referral
specific to
never
that
got
situation.
sent.
Yes.
I'm sorry that happened to you, first of all, and I'm sorry about that
It was
terrifying.
fine. Just
Okay,
whatever.
good.
But I'm sorry too, because that's exactly what's out there.
Right. Exactly.
So I think that referrals are one example of dozens of considerations that we have to take into account when we think about ransomware impacts. Many people never have thought about what happened to you being a consequence of ransomware.
Right.
That you had this cancer scare, and the person that was going to tell you whether or not you were going to live or die or need chemo or something like that never called you because an electronic message from the electronic health record never got sent to that provider.
Right.
Raise your hand if you've ever even considered that scenario as a consequence of ransomware. Raise your hand. There's a couple. Not many people do. And how many of those similar things, other than referrals, sending prescriptions to the pharmacy, blah, blah, there are many, many examples like that. To answer your question about something like crash cards, we do not have all the answers, but systematically going through and having people like you kick the tires on it means we add it to this list of like, well, how is CrashGuard going to handle referrals?
Right.
And how is it going to handle this case, in this case, in this case, in this case? And that's what the things that we need to get, prioritize, and then build into it. Because if we can't win hearts and minds about its effectiveness, or if people say it can't do all this stuff, we're not going to use it, then I think we miss an opportunity. So to your answer, the way we handle referrals right now is that a referral gets printed on paper, it gets signed, and then you go and have a referral that you can take to the person. You don't have to wait for them to call you.
Right.
But there are many things we're missing on that same line.
Sure.
On the HIPAA question, we've got a very, very limited amount of time, so I'll try and be as brief as possible, and we can commiserate on that. HIPAA is a law passed in 1996 to protect the portability of patient information. Primarily, the two parts that come into play with security are the security rule and the privacy rule. Privacy is, do you have agreements with other people saying that they can't do bad stuff with your data lawfully? And then the security rule is, how do you ensure that no one can break into your systems and steal stuff unlawfully? Both of those are over confidentiality rather than integrity or availability. And they also don't have anything to say about the safety and effectiveness of the systems. So you could totally have a situation in which the data you need is offline. It is tampered with when it comes back online. The systems that you use to implement things with that data go awry and hurt someone, and everything's fine with HIPAA. That's a massive policy failure that some of the I Am the Cavalry stuff has spent many, many years trying to unravel and improve. And I think we've actually made a lot of improvement in the medical device space, helping to empower the FDA over the past decade to have better pre-market and post-market guidance to medical device makers. However, that does not always translate back to the hospitals who still think about security as primarily a privacy thing rather than a safety and effectiveness of patients and treatment thing.
Thanks.
Can I just add one tiny thing to that? I don't think anyone knows if hospitals are closing because of the HIPAA fines. My anecdotal, again, bad evidence, is that that's actually the smallest part of the issue. Is that it's a class action lawsuit, and more also is that they lose a lot of money. Yeah, so cash flow goes and they see less patients because they go on diversion. The patients they do see, the way that hospitals bill is by documentation. When they go to paper, the documentation is so shit, for pardon my French, it's so bad that they don't get the amount of money that they normally would for the same care for the patient. And so they lose money from revenue for the patients they do care of, they take care of less patients, and then they're fined on top of it, and then there's a class action lawsuit 5 years later that they pay a big thing from. So what I'm trying to say is, I actually don't know if we said you're not gonna get HIPAA fined, that would change the equation. And I don't think you're gonna be able to give them like class action lawsuit indemnification because they got ransomed. I don't think you're gonna be able to stop the revenue. Like, I don't think CMS is gonna pay them the same amount for the hospital, for the patient care before the ransomware attack or after, so they still make the same amount of money. Like, what I'm trying to get at is, we don't know. I don't think it's HIPAA is a significant portion of that. I could be wrong. But what we should do is a study, right? We should take all the hospitals that got ransomed and ask them like, how much they lost and why they lost it, so we can say what the best policy targets are. If we want to stop hospitals from closing, we better get good data to make that decision. That data does not exist to my knowledge.
All right, great. So I work in IT, and your comments about staff safety resonated very strongly with me. I've recently been learning about the National Incident Management System and the Healthcare Incident Management System, and it's been very interesting. One of the side notes that's not related to healthcare or IT is the the National Wildfire Coordinating Group and its set of standing orders. They have 18 standing orders for all firefighters that fight in wildlands. A couple of them are the fire is not scouted or sized up. You are firefighting in country that has not been seen in daylight. Their safety zones and escape routes are not known. Now, while that's very useful for firefighters and not useful for healthcare or IT, these are 18 orders that are, if you are in this situation, you need to stop. You need to take a step back and assess what it is that you're doing. Could IT and healthcare benefit from a set of standing orders that says, if you are in this situation, it is better to do nothing and not become part of the emergency than it is to do something and become part of the problem? So what would those standing orders look like, do you think?
Nobody's coming, brother. So I'm just going to tell you, I am affiliated with many other nurses.
Mm-hmm.
We're all fighting for the same thing. We're all trying to do the same thing. And until we get some legislation in there, like I said, I've had staffing matrix in my contract since 2004. I put big teeth in it, and they're still violating it. They don't care. They need to be accountable either to the state on a state level or federal level, because until then, they're going to go profits over patients. And that's exactly I love the idea. I commend it, and that's what we're out there fighting for. So I'm with you 100%.
Thank you.
Okay, please join me in thanking our wonderful panelists for this fabulous,
You guys are
fabulous.
wonderful. Thank you guys. You guys are awesome. I love you guys. Love you guys.
Thank you so much. We are back here at 5 p.m. So for 58 minutes. Mr. Joss asked me, what are we going to talk about? We're going to talk about two very important things. One is food and food safety and food safety relevant issues. We all like to eat, don't you? I like to eat. You can look at me and say, Dave, I can tell you like to eat. So we're going to talk about food, and then we're going to talk about end-of-life devices with the stipulation that an end-of-life device should not end your life. Probably you're interested in that. So come on back at 5 p.m., and we're going to talk about both these things. Thank you.